Your energy and enthusiasm tells me everything is awesome. There you go. I sing that to my kids and they look at me and they're like, really? Really?
Oh. I feel like it's true. Yeah, that's what we need.
If you guys need to take a quick break or run to the bathroom real quick before we get started.
No thanks.
Go ahead real quick.
Getting deep. The actual one? Like a little sorry. Yeah, I do.
So if I remember correctly, I believe should be 4 people presenting today.
Really?
Yeah.
The 2, 3, 4 1?
4.
Oh, we got like 15 out of 19.
Yes, sir.
Yeah, well, all I have to do is
Because I got 3 submissions, so I'm all like,
and then
what there was 4?
job basically.
Oh, really?
Yeah. I was like, you don't have to interview or anything.
So you're not on 8 anymore?
Well, I have to get licensed.
When
And I have to wait. I have to wait till.
Yeah, I have to wait till the end of the Yeah.
semester.
No, I talked to him yesterday, and he's like, you said you graduated with 10 years. I said, you can do that.
Oh, so we could start now?
The email I got from my boss said you have to be here last year.
Either way, but then
Before it was last
What
year.
is the respiratory apprentice thing?
I don't know, but that's
So I got Emily, Kennedy, Anna, and Bailey presenting today. Sound about right?
Hey, what number am I again? Ryland?
You are. So you're our only presenter next week.
Okay, so next week.
And you have medication number 5, which was...
Okay.
Because I know that I thought she was in blood gas.
Yeah, I'll definitely go ahead and do
I'm
it.
not sure. She brings scrubs.
I brought the jackets, so if you want to try the sides and stuff,
You're all over there.
Tanya.
I know.
That's what we said.
Your sister's address.
Okay.
Yeah, you can just send it tomorrow.
It's on the soda.
I also didn't buy ours yet, but I'll get those.
I'm just kind of going how it was scheduled kind of last time, so I think because there's just 1 chapter this week that we're kind of going over, that's why it's like 4 presenters, whereas next week we'll have a little bit more
I can text you it
class to
later.
go over, so that's why we just have 1. Cool. No pressure.
Are you guys did she do the hoodies or the sweaters run on the size? I read that they run a little small, but I don't, she said she got.
You can shop them and try to like look at the sizes, and they're all there's we have like every size.
It's so cold in here.
Okay, I'll send it to her template if it's.
I mean, we can take it in too.
No, because
She has to do like 12 others.
Is she your older sister?
I have 2 older sisters. I have another older sister and an older sister.
Okay, Kennedy, since you went, you came up first.
She's like, oh.
Oh yeah, I hate my little brother. Why am I going first? Because yours came up first.
Because yours came up first, so.
Because you just sent it.
You're awesome.
Kennedy, it's good to do it first because then.
Send the bar really low.
Okay.
Sounds
Okay,
good.
so no pressure. Okay. The idea is you would treat the class as if they were a patient, more or less. And that's kind of the approach. So assume that we as a patient, you came in, the doctor has prescribed them some Flovent, and you would just kind of give them. This will obviously be a lot more information than you would actually discuss with the patient, but that's kind of the perspective we'd like to go with. Okay? So if everybody could give Kennedy your full attention.
Oh yeah. I love when I walk into patients' room and they clap for me.
Right, there you go.
Should I pretend I'm
And if you need me to change slides, just let me know to go to the next slide. It's surprised you guys don't have a clicker. There might be one, I just don't know how to find it or use it. But other than that, go ahead,
Okay.
take it away.
So, the medicine you were prescribed by your doctor is Flovent HFA. It's also called fluticasone propionate. So this type of drug is a corticosteroid, inhalant, anti-inflammatory, and adrenal glucocorticoid. That word. Yep. Okay, you're good. So this is the dosage. So you're not a pediatric patient because it's not really indicated for peds patient. Nasal inhalation is 1 spray in each nostril twice a day. It's about 93 mcg each equals 372 daily. There is an ointment for, I'll get to indications, but that's just twice daily and you rub gently. And then aerosol is usually what it's used for. It's about, so like initially you start off at 80 mcgs twice a day, depending, it just depends on what you need it for. So indications are allergic.
Rhinitis.
Yeah.
It's a runny nose.
Oh, okay. Asthma, atopic dermatitis, dermatosis, which is the skin disorders, and then like nasal cavity and sinus. That word he said non-allergenic. And then contraindications is hypersensitivity to any of the component of the product or milk product. If you have active tuberculosis, thrush, parasite infection, glaucoma and cataracts, and decreased calcification and bone density. Infant risk cannot be ruled out, so it said it's fine for pregnant, but not for breastfeeding. Cannot be ruled out, so that would be a contraindication. So the side effects is mainly nausea, vomiting, breathing problems, eye pain and vision problems, fever, worsening asthma, stomach pain, jaundice, rash, and bowel problems. The effects on the cardiopulmonary system, it affects the lungs by decreasing inflammation. It's not fast acting and should not be used in an asthmatic episode. It is also found in mainly older patients. I think it was like 60 years plus. Heart palpitations is found. And then for an RT, education is important when explaining at-home medication. Understanding how to properly educate each patient is important, and being able to teach each patient with different levels of understanding. Also knowing common problems and how to troubleshoot those issues. So like with Flovent, you shake the inhalant well before each use. Following inhalation, rinse mouth out with water and then spit out water. Do not swallow. Flovent should not be used with a spacer. And you should never wash the mouthpiece or any part of Flovent, and keep it dry in cool, normal conditions. That is what I did.
Good job.
Any questions for your respiratory therapist?
Well, like, can I get some water?
Well, let me grab yours.
There you go. Good answer.
Thank you.
What kind of bowel problems?
So, mostly constipation is what it talked about, as well as stool. I don't even know. It said something about like your stool is not normal, basically. So you're like, oh, it's fine, and then it comes out not normal. So I just put bowel problems. That wasn't about to write stool. That felt weird. But yeah.
Any other questions?
Oh, I do. Is there a way that we can get these posted campus so we can like review them for like a test?
How, if you show me later how to post it,
Yeah.
so that everybody can see it and use it, then I'm more than happy to do that.
You can,
Is-
yeah, you can download all of them in the end in a folder and just share the folder.
Okay.
Something in your Google or something.
Okay. Yeah, we'll figure out a way. As long, so technically, because Kennedy made this slide, she is the owner of the slide, and so she, as long as you guys are okay with the sharing of the information, as long as we're all on the same page, I don't want anybody suing somebody else for copyright infringement.
This took me a lot of work.
Okay, consent, everybody needs to
Can
provide
we charge
consent.
to have them?
Technically, you can. The only reason I say that is because if you guys, going forward, if you guys pursue more education, a lot of professors and teachers are very, very OCD about their slides, their information, even something as simple as recording like their voices or videotaping. There are people who are very crazy about that stuff. So anytime with regards to sharing stuff or using stuff, or like say if there was a killer, if there was a really good slide and then going forward you wanted to use it, I don't care about my stuff, but that's not the case with everybody. So just be aware that is a thing, especially in the healthcare world. A lot of the material that people create, that's, they own that per se, and so some people do get uppity about that. So that was your warning. Okay, good job, Kennedy.
Thank you.
Let's see, who else is on our list? Let's see. And Emily and Bailey.
Well, there you go. The bar set.
That's so good.
I know. I think it was way better than mine.
Yeah, way better. She should not.
I know you said we were supposed to do like a patient, and I completely blinked. But I would have made it a little.
You're a good therapist. We like it.
Thank you.
If I ever get sick, I wish you.
I'll be your therapist, Maggie.
Okay, Emily, you are next. You really have 10 slides?
Yeah, but they're like really simple.
Y'all some overachievers, okay?
No.
I thought my 3 slides were long.
All right,
You
so
kind of said that we can do as many as we want.
yeah, that's a lot, yeah.
They're just very simple.
Okay, that's fine. Like I said, to each your own. How you guys want to go about it is fine. I was just like, oh man. Okay, sorry. Go ahead.
Okay, so my drug is Triamcinolone Acetonide. That's how you say it. Just in case I forgot. And then the brand name is Nasacort. So this is a type of drug of a corticosteroid. So the indications, if you're having an itchy or runny nose, sneezing, or any side effects of seasonal allergies or hay fever. You don't want to take this if you have open sore or ulcer in your nose, if you get frequent bloody noses, recent sinus surgery, certain eye conditions like glaucoma, cataracts, or intraocular pressure, untreated tuberculosis or herpes simplex, recent exposure to measles or chickenpox. The adult dosage is 55 micrograms, and you're just going to want to spray it in each nose once a day, maybe twice if you need it. The side effects, you could get a sore throat, a nosebleed, headache, cough. The more serious side effects are nasal septal perforation, infection of the nose or mouth, glaucoma, or cataracts. And this relates to respiratory, just to like clear you out so you can breathe better. Woo! That's the end. Very simple.
Any questions for your respiratory therapist?
What is nasal septal perforation?
It's a good question.
Find your nasal septum.
I don't know.
Perforates.
If anything, it's a big hole in your nasal septum.
Okay.
Or, if somebody has a nose piercing, like right through like a ring or something like that, that's technically a nasal septum
Not me.
perforation. Let's see. Yeah, any questions?
I would.
Is it like over the counter?
Ask your RT.
Is it over the counter? Is it prescription?
Yeah, I think you can get over the counter.
Ooh.
Any other questions? Okay.
I was asking some therapists about it at work, and they said they never see it. So probably not a drug we see it on.
So because it's over the counter, it's not something that as an RT you'll necessarily see a whole lot of in in, say, the hospital setting. However, it's an easy fix for any of your patients who might be having either seasonal allergies or asthma problems. You know, it's an easy, hey, you know, try some Nasacort. It is available as a prescription, as well as a over-the-counter. You'll see there's a lot of commercials for it and stuff like that. You can pick it up at any pharmacy, but it's a simple and easy respiratory-related option for your patients.
Is it usable in a long term?
I didn't see that. I'm sorry.
That's I'm gonna get your nurse.
I'll go to the pharmacist.
Yeah.
Let me flip that out.
So patients who have either a history of asthma or have a history of seasonal allergies, they can. Usually it's an as needed kind of thing. Like if somebody goes to the ER or goes to their primary care doctor and they're like, oh, I'm having constantly running nose, my eyes are watery and itchy, I'm having a hard time breathing, that's like an easy go-to for doctors or for patients to kind of get some symptom relief.
So it's just like an instant symptom relief?
Because it's a nasal spray and we have lots of capillaries in your nose, and so that's why that's an option and a method for it. But the funny thing is, although Nasacort, when it's available over the counter, like we won't, as an RT, you won't see it in that setting, but we use Triamcinolone with some other inhaled medications as well, so that's where you see it. When in doubt, like I said, you know, if your patients are struggling to breathe, we're always trying to look how we can help our patients breathe better, and you know, something as simple as a steroid nasal spray can be super helpful for them to kind of just calm things down. That's what, whenever you hear or think of a steroid, you want to just realize that a steroid will help reduce inflammation, reduce swelling, reduce irritation, and kind of calm things down. So if you have an asthma exacerbation, if you have bad air quality, you know, when we have fires going and stuff like that, you're going to see an influx of patients coming through the ED. You're going to call respiratory for a breathing treatment. You're going to give them some steroids orally, but like I said, you know, going home, they're like, oh, you know, hey, what's an option? You can say, hey, if you pick up, you know, some Nasacort or some Flonase, those are some easy fixes for patients. Okay? Questions? Good job. All right. Let's see. Who else did I say earlier?
Call her out.
So is that kind of the same as like Afrin?
Afrin's different.
Okay, because
It's the same. It serves the same purpose, but it has a different in pharmacy what they call it mechanism of action.
Okay.
But it's the same. Like when you go down that aisle of allergy meds, you're going to see Flonase, Nasacort, Triamcinolone. You'll see store brand. You'll see brand names. Some patients you'll see swear by brand names, so it's available. But I'm like, generically, it's the same thing. You know, maybe different fillers, but you'll see different medications for the same indication, but they'll have different ways of working.
Because if you take Afrin too much, don't you like get to the point where you like rely on it, where you have to like take it all
So
the
the
time?
concern with some nasal steroids, but especially for Afrin, is what they call rebound congestion. And so the idea is when you use it as needed sparingly, it'll help reduce your congestion. But if you overdo it, now instead of reducing it, it's actually going to cause like a super episode of congestion. Good questions. Sorry, who else was going? I know Anna sent me hers. I had on her. Give me 1 second. Sorry. I don't know if it came across that way. Anna, did you submit it in Canvas? I know I have it on my Gmail account.
You know what? I sent it to you, but I don't think I submitted it in Canvas.
Okay. 1 second.
Let me just email it to you.
Did you change anything or update anything since?
I did, but with the link, it should update it.
Okay.
Yeah. Okay.
Okay. All right, take it away.
All right, so I have Mucomist. It's acetylcysteine. Has a couple other generic names, but and it comes, in dosaging in that bottle, but it helps clear thin secretions, clear out mucus, so it's the name helps describe what it does. And
Oh, sorry. Let me know when you want to go.
And then yeah, it has it's derived from the amino acid. I can't remember what the name of it was, but it helps break down the thickness mucus, which I thought was interesting. Okay. And I can't see from there. The uses are, like, it is labeled for acetaminophen overdose, and I think the way to remember that is acetylcysteine and acetaminophen start the same. So just remember that it is actually indicated to take orally for a Tylenol overdose. And then they can use it during anesthesia to help with just like mucus production and everything. But then the ones in bold are the ones that apply to us the most, like Adora Ellipta for mucus obstruction, any just acute or chronic respiratory disease, anything post-surgical, cystic fibrosis, although pulmozyme is more used for cystic fibrosis than Mucomist. And then, but anything that we want to do to clear mucus and thin secretions, and also with tracheostomy. But it did have some interesting off-label uses that I listed, kind of obsessive compulsive disorder and things like that, if you want to, and scratching. So I thought that was interesting, but more for us, any pulmonary, extra secretions is good. Okay, sorry, I thought that was pretty good. So you don't want to use it during an asthma attack. It can exacerbate that. If the patient can't cough up all the secretions, you just want to be ready to suction them. It doesn't really have any known serious interactions, so just if they have a hypersensitivity, be aware of that. But again, knowing what it does is it'll increase their cough productivity and improve their work of breathing. So their SpO2 could go up, heart rate could go down. You can combine it with chest physiotherapy and just help get everything loosened up and moved out.
How many of you guys used vest therapy for your patients yet? Anybody?
Just on a mannequin.
I tried it on myself.
Did it help?
Yeah, I put it on myself and I think it's awesome.
Okay. How many of you had to do actual percussing? Has anybody had a chance to percuss any of their patients yet? How did that go?
Thank
All right. The RT was like, let me try.
Okay. In all honesty, not too many patients are down for the manual percussing. Although I have worked with some RTs who are like frigging machines. John Bradshaw, I shadowed a lot at IMC, and he could just go for days. And I'm just like, yeah, I'm gonna tap out, dude, after about 5 minutes. Like I said, if you do have a chance to work with some CF patients, some of them are still a little old school and prefer that. So
If the vest helps, why would you go manual?
why would you what?
Go manually. Why?
Just what they're used to.
Because what people like,
Usually
a lot of people don't like it.
people will gravitate towards what they're comfortable with. And so if being in a vest, the hoses and the movement messes them up, then that might be a reason for why they would like, oh, okay, if an RT just does percussion, they can get to one particular area, it's more specific to a location where you're working on. So because you're gradually trying to shake things up so that it moves and they can cough it up, or cough it up and either spit it or swallow it. You might have, has anybody had any CF patients who save their secretions?
No.
Save
Okay,
them.
yeah, be aware that patients will, CF patients or some patients who have a history of respiratory problems, in all honesty, their secretions can tell you a lot about them, their diet, their habits, and how often they come in for their clean outs. And there's one or two patients who will save their jars of their secretions. And so be aware, if you walk into a room and there's a bunch of jars lining up and you're due for their cleaning, that's what that is. Please try not to vomit, choke, or get grossed out. But that is something you will see and can see for a patient. Usually it's like a week or two clean out. I actually did have a patient I did a consultation for my job, and apparently there's a new medication out on the market for CF patients, and he hasn't had to go into a CF clinic for several months because this new CF medication is like helping out a ton. Patients can go into IHC some facilities to get cleaned out, but the U actually if any of you do rotations or end up working at the U, they will see CF patients more often. And then if any of you do rotations or get picked up at primaries will also see a lot of kiddos with CF and stuff like that. So stuff to be aware of. Sorry, I didn't mean to get off on a tangent.
No, that's good. The dosaging, you're almost always going to be we'll be giving it through SVN, and you can either do 10% and 2 4 milliliters of that, or 20% solution, 1 to 2, and dilute it, and then give them 2 milliliters, which ends up being about the same. And that's the same for pediatrics, so it's kind of just a across the board safe dosaging. But you can give it orally or through IV for the acetaminophen, or they did inhalation also for anesthesia. There's pills, there's different ways, but for us, we would just do the inhalation. It does smell really bad.
Has anybody had a chance to smell it yet?
I haven't.
Okay, it has like a sulfury, rotten eggy smell. And so you'll know, or you'll get used to it if if your doctor is like, oh yeah, I want them to get mucomist, it's gonna smell bad. So
yeah,
I will not do that.
Just be aware. It smells bad. It can turn like pinkish purplish after it's open. Like it can just change color, and that's normal. Like a light color. Yeah, and keep an albuterol close by or something if it causes bronchospasm, or be aware of wheezing and shortness of breath. But I don't think it'll increase really their heart rate.
So yeah, so there are medications, unfortunately, that can cause bronchospasming. So PRN, albuterol treatment might also accompany it. I'm not gonna. Unfortunately, a lot of CF patients who they don't live for very long because a lot of complications related to it. But a lot of times when you walk in, even as a new RT, they know their treatments. They pretty much just need you to set it up and hand it to them, and they'll do everything on their own. You just chart it, you document it, always document everything you do. But fortunately, like I said, they know their treatments. They know what they need to do to get cleaned out. Any questions for your RT guys?
Is it making you cough or just helps coughing it out?
I think it does increase, make it easier.
There's put it in a little air.
Clearing the mucus.
No, they do it for them.
Yeah, I think it can.
So like she said, the purpose of the medication is to make the mucus thinned out. So if they're having a hard time, so like pneumonia or any kind of complications, the gunk and the crap is just stuck in their lungs. It's not moving. And so when they do a mucomist treatment, it's getting into their lungs, it's thinning out the mucus. So now when they cough, when they do flutter valve or anything like that, now it's actually going to move and they can get it going.
So when we need to get a sputum sample, there are medications that they can induce the cough. Is this one of them?
You could, but this wouldn't be one of them. Unless the doctor, this would just be to thin it out for the purpose of, clearing things out. It wouldn't necessarily be one to, that we would give them or ask for to induce for, a sputum sample. Because I'm trying to think, because, sometimes, I'm trying to think, sputum, how many of you have seen or had to have had a patient give you a sputum sample yet?
I suction, but I haven't done.
Okay, share with your classmates who haven't done one yet, what that experience was like.
It is pretty
Mine
gross.
was on a baby. It was kind of sad.
Okay. Oh, speaking of babies, okay, do any of you have young baby-age children yet? Okay.
No.
I want you to
Almost
know that when some of you will have to help out with bronchiolitis clinics when the time comes. Be aware that you are not hurting the baby. Okay. Although it might look a little rough, the idea is you're trying to help them, you're trying to suction them, and there's not medicine for babies at that age yet. So the only thing that's helping them is you when you shove that super long suction catheter down their nose, because you're trying to get them to cough, sneeze, anything to move that mucus out. So ask, if you guys, next time you guys go to rotation, ask your facility or your preceptor about bronchiolitis clinics and stuff. The hardest part isn't even the suctioning. It's one, convincing the parents that it's going to be okay, and then two, trying to fit a pulse oximeter around a little baby's foot. That's a pain in the butt and super hard. So when you guys practice that, have you guys practiced that yet in lab? Okay, just know that a squirmy baby foot is super, super hard to freaking put a pulse ox monitor on. Okay, thank you. And then
I was like, who's James? But I know who James is. So I did not get the memo that we were all doing PowerPoints. So this is my presentation.
which is perfectly fine.
Thank you. Okay, I have albuterol sulfate or provincial HFA or Ventolin HFA. It is a bronchodilator or a beta-2 adrenergic agonist. Some indications for albuterol are management of asthma, management of exercise-induced asthma, acute bronchospasm, and COPD treatment. Any contraindications are like hypersensitivity to albuterol, levalbuterol, or any milk proteins. The adult dosage and administration, the MDI dosage is 2 puffs, 90 milligrams, or micrograms, okay. And then the nebulizer, they can do inline, I don't know, I put Aerogen for fun. I did 2.5 milligrams. Pediatric dose, I just did ages 2 to 4. And administration, the MDI dosage is 1 to 2 puffs, 90 micrograms. Is that true?
Yeah.
Okay.
Oh yeah.
I couldn't find anything else, so I thought that was a lot. But and of course they'd have to have a holding chamber to help with the dexterity and everything. Nebulizer would be 0.63 to 2.5 milligrams with a simple face mask. Side effects to the heart and lungs: tachycardia, palpitations, cough, shortness of breath, dyspnea and wheezing. Other side effects: tremors, anxiousness, nausea, vomiting, naropharyngitis, anaphylaxis, upper respiratory infection. A note: beta receptor blocking agents and albuterol inhibit the effect of each other.
Okay.
Boom.
Any questions for the RT?
I do.
Oh.
So if you actually experience any of these side effects, what should I do? Like, should I stop the treatment or just
Tachycardia and tremors, they're normal. So you just have to let your patient know that it is normal to experience those. I'm assuming if they're vomiting, you would probably want to stop, but yeah.
Any other questions? Okay, so with albuterol, you guys will administer more albuterol than anything else. And similar to the slide, you'll either do it as an MDI for your patients when they get just discharged. You'll give it as a SPN nebulizer, either to the patient in their room, or if they're vented, you'll put it in line. Have any of you put an SVN in line yet on a ventilator? Okay. Any problems, questions, concerns? Who hasn't put one in line yet or seen it? Okay. You know, the funny thing is, with adults it's fine, and usually you're just, what you're looking for is for the oxygen levels to go up. When you put it in line on with a vented patient, a tube patient, what you're looking for is you're trying to open up their airways to decrease their work of breathing. So their work of breathing, their respiratory rate will usually be relatively high, like they're working really hard. And when you put that nebulizer in line, it might take a little bit for them to feel the effects, but once they do, you'll notice that all of a sudden they don't look like they're having to work as hard. Their oxygen levels obviously are going to go up. Have any of you had to give a kiddo any nebulizers or MDIs yet? Anybody? How did that go?
The kid did not like it at first.
How old were they?
They were 4.
Okay.
And it was like
And was it an MDI or nebulizer?
Nebulizer.
Okay.
They had to wear a mask, and I just let it, or her, color on my gown since I had to wear a gown.
Okay.
And then she calmed down.
Oh.
Okay. You guys will find, you guys will see, I would say unconventional methods of administering it. Adults is fine. The hardest is always giving it to kids. And so how many of you are familiar with like blow-by? Okay, so that is a feasible option as long, how many of you are not familiar with blow-by? Raise your hand. Okay, so in the event that, you know, say in this case you had a 4-year-old, okay, that's somebody you can technically, even though they're not playing ball, you know, you can tell them, hey, you're going to put this nebulizer in your mouth, you're going to breathe in, and you know, it's going to help you breathe better. Okay, but with little babies and stuff like that, when you listen to their breathing and you hear wheezing and you hear crackles, you know, they're not the easiest to slap a mask on or to give directions to. And so you'll actually see, I'm sorry I don't have the equipment for it, some RTs will take, I will let you know that RTs are like the MacGyvers of the hospital, because they will finagle stuff to get the job done. And so you might see somebody take like a nebulizer setup, and where the mouthpiece would go, they will actually take plastic and cover that and then jam the mouthpiece in there so that it's only coming out of the extended tubing. And you'll see sometimes they'll put that right just in the baby's face, right where they're breathing, and that's better than nothing. So you guys have to find out what works best for your patient, and in this case, if any of you work with babies, you know, you might see a setup like that, or you might see where if it's a kid or even an older patient, you'll see their breathing, and you guys got to coach your patients too. Okay, so if your patient is breathing, you know, that's not going to be an effective way with a nebulizer. That's not going to be an effective way to get that medication in there and for them to reap the benefits of this treatment. And so you have to coach them and say, hey, do me a favor, I need you to breathe slowly, I need you to calm down, I need you to, you know, on occasion maybe hold it in so that the medication can saturate your lungs. Okay, a lot of, you know, fortunately there aren't very many things as RTs that you'll be required to do, but like I said, a lot of it is a lot of coaching. You'll hear the word coaching a lot when it comes to RTs, because you have to be able to coach your patient in a manner to get, you know, to get them to do their SVN, to do their Advair, you know, to follow directions. And so that's a huge part of your role as a healthcare professional with these patients. I've seen it too where somebody might take like a rubber band, and when an older patient or a kiddo is an SVN, they might rubber band the tubing so that it actually, you know, comes back into their face so that they're not losing any of that medicine. You know, the mask, you know, a mask helps if they'll tolerate it. But if that kid's pulling at the mask, or an older patient is pulling at the mask and they're not doing it, if you're something just as simple as, you know, it blow by into their face where they can breathe it in, that's something that's better than nothing. Okay? But yeah, Albuterol, learn it, love it. Let's see, the tremors and increased heart rate are definitely very common side effects, especially the tremors. If you ever have a asthma exacerbation come into the ED, I believe the formula is like 5 albuterols, 2 atrovents, and enough water to fill it up, because they're going to do this breathing superneb for about an hour. All they're going to do is sit there with a mask on and just breathe in this concoction. But that's like, some doctors will prescribe it, and so you'll have to just get everything you need. And then you just kind of sit there. Your job is to monitor the patient while they're doing the treatment, making sure that 1, they're doing it right, and 2, that they're not getting too crazy with it. Any questions? Albuterol, it's your friend. Okay.
Wait, sorry. So with beta-2 adrenergic agonist, could we also call it like a sympathetic, or?
Maybe. I would have to take a look at that. Let me call your nurse. Yeah, no. In essence, you could, for testing purposes, that might be a better way to look at it, because I guess. Oh, and with regards to the quizzes and stuff like that, I will admit, I haven't had a chance to go through and like take out some of the bad ones. If you have questions or concerns regarding some of the quizzes, let me know. I'm not, this course should be helpful, and I don't want you guys to stress out over it. I will make sure you guys are taken care of. But yeah, other questions, concerns? Okay, good job on the presentations. We only have 1 presentation next week, so no pressure whatsoever. It better be freaking awesome. Fireworks. I'm expecting grand things from you, sir. Other than that, let's take a quick break before we get into our slides. I'll come back in about 5 minutes.
I love that video.
Oh, and then I made her mad.
Good job, everybody. Good job.
You love it.
Yes.
Your list about
I'm gonna make cookies.
Don't touch the
Yeah, I made a
mirror.
list. I'll post it. Is the discussions, does everybody see discussions about on Canvas if I post it there? Yeah. Okay. But ahead of time, I'll let everybody know, hey, next week you have presentations. So
Wait,
next
did I
week we
make you
only have
cry?
1. But then the following week, then we'll review and make sure everybody is aware.
Oops. She said, I got the one for you. Follow me. Ooh. Too real. Chrome down me. I don't need it. I'm done.
What was yesterday?
Monday.
Because I sent it home.
No, at work. I wish. I was on restock yesterday. There were 2 items that needed to be restocked. And it was 2 items I could not find.
Wait, so how does it work in session?
Do you like make them more good?
I work at Lululemon. Lululemon. Super fun. But
Do you like make like a paper and how does it work for your shit?
we just have like a little screen, and so if like there's 3 items of like a product same size and someone buys one, as long as there's 2, it won't call for another one. But as soon as there's 1, it'll pop up on the screen to go grab. So there's like 2 of each size. So there are 2 items. One was a face mask, which we don't have in the back, and then one was some shorts that are mysterious.
Just from curiosity. So I don't think, as you know, we're like very close friends here.
Girl, you get 25% off. Y'all are healthcare workers.
Wait, what? There's a discount for where?
Lululemon.
Because we're very close friends, you know. So if we're closer, he's gonna be like 30.
I know, I wish.
Okay.
I mean, if you come in, just be like, show me your badge. I'll be like, ah, yeah, how long have you worked there? Put it in your profile.
I love this store. I really love it.
Yeah, you get 25% off. So do flight attendants. If anyone else is going on a different path in life, there you
Be a
go.
flight attendant.
We were talking about that.
I feel like you would be a flight attendant.
I'm too short. There is a height.
Shut up.
What is it?
There
What's the
is?
age requirement?
Like
I thought you were,
5'4".
there was such a thing as too tall, but not too short.
And they said for safety issues,
You have to be able to see above the shirt.
Let me check.
Airlines?
Wow.
Probably not.
So
Flight.
Oh, you get on the airplane or
Oh,
the
you are?
helicopter
By
flight?
3?
that's what I'm planning.
No, like my flight was
Yeah,
good.
like a good
You were so close.
I'll get on a plane one way or another.
Right.
That'll work, right?
All you,
there's-
this is United.
There's this procedure. So you can extend your life. It's very
Oh,
painful.
yeah. I saw that in Vegas.
If you really want it though, we can make it
Make
happen.
you a little taller.
All United flight attendants must be at least 21 years old at the time of application, have a valid passport. Height-wise, they should be between 5'2" and 6'3" without shoes.
5'2" and 6'3".
Yeah, 5'2" to 6'3". So if you're 6'4" or 5'1", you're out.
5'1".
Sorry, girl.
5'1".
With shoes on.
I don't know what I'm not without. Oh yeah, look, because you're between 5'0" and 5'1", you're below the minimum height requirement for most major airlines.
Oh, yeah.
You may not be tall enough to reach the overhead compartments. But don't let this discourage you.
So hard. And she goes,
My legs is really hard.
I'm right there. And he goes,
Damn, I can't even be a flight attendant.
did you know
Yeah. Funny.
Where can't short people work?
Different.
A model.
Model, yeah.
Damn it.
I'm not even tall enough to be a model, so it's fine.
Here are some that suit short people. A jockey, like a horse. That's good. They are really small.
Guys, I'm moving to
Long distance
Oh,
runner,
yeah.
no.
fighter pilot. You can be a
I was
hairdresser.
like goatee, though.
pilot. A clothing model for shorter people. For shorter people.
Whoa.
I don't like this anymore.
Also jobs which require you to fit into small spaces, such as welding, plumbing, electrician, and finally jobs which require balance, such as dancing, choreography, and hunting.
And then
Hunting?
she did a PhD on me.
I'm gonna be a hunter!
Yeah, I was like,
Here, what are things tall people can't
my
do?
doctor was like,
Down in the woods,
They can't be a pilot.
under a tree, hunting, finding a deer to
did
shoot.
it on me.
take a shower, take a bath.
It has to eat.
Yeah. So try to do
What
it.
tall
I was like,
people
wow,
can't do.
actually, I feel bad for these people now.
So if you're tall, do not think to shower. You can't.
Don't take a bath.
Okay, 20 jobs for short people with the salaries. You can be a delivery driver, short order line cook, another delivery driver.
I love that they had to put that it was a short line cook.
Yeah, you can be assistant for press, telesales, you can work from home, local fruit and vegetable harvester, bartender.
Basically.
You can be a full-time crew member at Burger King. This must all be in Canada.
I feel like they just put it.
Close to me.
You can be a truck driver.
It's Diane.
I don't
Skill level.
Yeah.
That's not the one.
You can be a sales associate at Spirit Halloween.
Yeah.
What am I dressed up as? Like the troll under the bridge?
All right, everybody ready?
Yeah.
Dive into the world of bronchodilators.
Did you bring the toll? Who's your lousy toll? Oh. Oh, I was like, my favorite part is when he goes, he pulls out the gun. He goes, no, Antonio, you cannot control me anymore. And the gun just comes out of the door. And he's like, what the hell is that? He goes, bitch. Bow! Bow! That's the song.
Alrighty, bronchodilators. Any questions about bronchodilators?
Carly's got one.
Go.
Okay, that's not bronchodilator, but can you define like what's racemic?
Epinephrine.
Yeah, or no, like the word just racemic.
This is a mix.
Fast.
Mixture.
Mixture?
Yeah, that would be, so, I want to say, so like racemic epinephrine, so like how there's levalbuterol and albuterol, okay, structurally, they're mirror images of each other, and so there's, a couple, so when they talk about racemic epinephrine, you might see it like be 50-50, that just means it's a mixture of two different types for the best benefit for the patient.
Okay.
That's how I interpret it. If I'm totally wrong, I apologize. Any other questions? Clear as chocolate milk?
Yeah.
Let's see.
Do you ever watch It's Always Sunny in Philadelphia? You've never seen it? It's amazing.
Is it old? Like an old movie?
No, it's a TV show. It has, what's his name? Danny DeVito.
All right, so defining key terms, bronchodilators.
Literally died.
I will admit that for this course, they want you to know a lot of the minute details. Hopefully, going forward, there will not be another time where you will need to know such minute details. So like when it says, describe the neurologic control of bronchial smooth muscle, sympathetic and parasympathetic nerves. That's a lot of big medical jargon for just knowing how it works. Because ultimately, for this course, you'll be quizzed and tested on it, but like come your boards, will they ask you about this stuff? No. So when I did pharmacy school at Roseman, there was a lot of learning it and then discarding it. So as far as like some of this, like the knowing smooth muscle interactions, nerve interactions, chemical mediators, will you need to know a lot of it when you step into the hospital? No. But you will need to know the bigger picture stuff. So medications causing bronchospasms and bronchial constriction, bronchodilation, some of these other things that are mentioned, methylxanthines, nobody uses that. Like you guys will literally see, for the most part, 10 medications at most that you'll use in your bag of tricks. But the more you know it, the better.
But I have one more question.
Yep.
So with like conversions, if they say like there's 10% strength of a solution, that would be like 10 grams to in 100 milliliters? Like if you were setting that up?
It depends how much. It depends when you set it up. It depends on what your, I guess, solvent is. What's the big volume you're putting it in? So, like when we do stuff, say for a superneb, it'll be by milliliters. But other times, for some of the equations, it might be into like an IV bag, and the IV bags the size can change and vary.
Oh, so
but like if it's usually like if it's 10%, then you would be like, you could calculate out the volume of your stuff. What are you trying to get to?
I was like trying to understand, because like one of them was if you have a 10% drug solution on hand and the order states to deliver 100 milligrams of the drug, how many milliliters would you deliver? So they set it up and put 10 grams over 100 milliliters for the 10%, and then you're delivering 100 milligrams of the drug, so you need to know how much of the solution to give. So I just was like trying to clarify, like the 10% drug solution, that's like the strength, and so then they just put it into 10 grams.
Ask me about that one after this.
Okay.
Because I can math it, I just can't math it. I have to write it down.
Yeah.
I'm all write it down.
I have a question about that too, just converting it. I don't know if we can talk about it.
Yeah, well, we can easily go over that. Let's wrap up this lesson, and then I can stay after. You guys are it for me, and then we can go from there. Any other questions with regards to bronchodilators yet? So, fortunately, we had a presentation about a bronchodilator, Albuterol. All of the presentations are awesome. Good job. For some of the medications, at least for this lesson, it says we'll state some indications, some contraindications, some side effects, a little bit of onset and dosage range. In all honesty, the slides didn't go that in depth, but we'll take a look at that. Recommend appropriate bronchodilator therapy for various patient situations. When in doubt, is an albuterol treatment going to hurt somebody? No. So if patients are struggling, go do it. The only thing that might vary will just be how often. And there might be times where you come in and they're like, oh, I need a treatment. If you assess them and they don't need it, then you can just let them know, hey, based on my assessment, everything looks good. You can do a treatment, or you can just, I can come check on you later. There's a lot of different ways you can play it. Let's see, and then it says we'll discuss techniques for monitoring patients. Have any of you had a chance to go work do PFTs yet? Okay. How was doing PFTs? Shared with the class?
It was really fun.
Okay.
It was really interesting we did stress tests as well.
Okay.
So,
nice.
But
how many patients did you guys see while you were doing it?
There were 2 for PFTs and 2 for stress tests.
Okay.
I was only there for 4 hours. So.
Okay.
But yeah, it was interesting they did one on me too. So,
oh, okay. How'd you do?
I did okay. I have asthma, so
okay.
I mean, I did as good as I could. But it was cool to see them in the box, the body box, and they have different mouthpieces because some people get their tongue in the way and stuff. But yeah, it was interesting.
Okay, sweet. And so PFTs is one way that we can help to assess how good or how bad a patient is, work or breathing is. So let's see, that's awesome. So as far as airway anatomy and physiology, so there are 3 layers of the airway. They have the mucosa and the ciliated cells. How many are familiar with what cilia is?
Just the little hairs.
Just the little hairs, the fingers. Okay, and let's see, there's a submucosa, so that's the bronchial gland, smooth muscle, capillaries, and elastic tissue, and the adventitia. Trachea. How many of you have how many haven't worked with a tracheostomy tube yet? Okay, for those of you who have worked with a tracheostomy tube, how was that? Wasn't very fun, right? Well, how many of you have seen like a metal trach? Okay, metal is old school, and you'll get some older patients who still do it. We had one patient, when you asked him, hey, do you know how to clean your airway? He actually popped it out, threw it in his mouth, swished it around, and then popped it back in his neck.
I would throw up.
Please excuse me.
So, good time.
Please excuse
Did
me,
you have a
like,
question?
gag.
Question?
I don't know, I had, there was this old patient, I was at the LDS, he came to the ED, and he had that kind. They told me, I didn't know, they said, oh, he has the old-fashioned one, metal one. I said, what are you talking about? And they took it out, so we actually sectioned, so I didn't really see it. But I heard about it.
It's really small, it's really tiny, but yeah, that's old school. So if you do come and just know that originally they were metal, but nowadays you'll see it like a hard plastic. Heaven forbid you ever lose a trach tube, okay? So if you ever have to go clean or do a treatment with a patient who has a trach tube, you have to be comfortable with, at the least, being able to place your hand on it. So if they cough, sneeze, or fart, that this thing does not shoot out of their neck, because it is a huge pain to have to rethread this thing back into them. So please be aware, trach tubes, like if you have a patient who has a trach tube, it's kind of grungy, but it's super important that you help ensure that this thing does not come out. I unfortunately had the chance to see a new resident trying to place a trach tube in a patient who was involved in a car accident, and I watched this poor lady get her throat like pierced multiple times. Pierced multiple times by this resident because she wasn't getting it. And like every time she's just like right here and just stabs it in, and her attending's like, no, you gotta go lower. She's like, how about this? And the whole time my neck is just like, oh. It happens, everybody's learning, but like I said, please be aware that trach is super important. And so whenever you have to work with it, you need to be, one, comfortable with it, but two, always be aware that a cough, a sneeze, something can easily make that thing shoot out. A&P, so we got the trachea, left and right, main stem bronchus, large airways, the bronchi, which then become the bronchioles, and then the bronchioles become smaller airways that don't have cartilage support. This is a rough picture or diagram of your airways. Have you guys done, are you guys first year or second year?
First
year, okay. Have any of you had a chance to intubate yet? How did that go?
It was good.
Okay. So when we did rotations, we went to LDS Hospital in the OR. You guys will get a chance to work with the anesthesiologist to intubate patients. I would say, so there's like a line of succession when it comes to intubating. Obviously, the more you do something, the better you are at it. And then you'll also know which of your doctors and providers are good at it and who suck at it, and who you'll need to provide more support. But yeah, like there's a lot of different ways, but you want to make sure if you have to intubate somebody that you have everything that you need before you get started, know who you can ask for help, for backup if you ever have to do it. Usually we don't do adults. Like there's a long line of like doctors and NPs and PAs who want to do it. Fortunately, there's a lot of like scopes that are super helpful for doing it, but I have seen where in the NICU and at primaries that the RTs do a lot of the baby intubations because they're just more reliable and more familiar with it than doctors are. So something to be aware of. No pressure. Bronchoconstriction versus bronchospasm. So bronchoconstriction, in essence, all it is a reduction in the diameter of the airway. So it just gets smaller, so it's harder to breathe for the patient. There are 3 different mechanisms. There's a bronchospasm, inflammation, or secretions. So Yeah, everything that we do for respiratory therapy is to open the airways, increase breathing. So, like that's where that's where your bronchodilators will come in. Will come in. The inflammation. For some steroids, that's where that comes into play. Or for the bronchospasms, that's where the bronchodilator comes into play. And medications like Mucomist or saline, that's where you'll help out with managing secretions. So this is a picture of what your normal airways will look like. Everybody says they look like a cluster of grapes. Just imagine they're a bunch of small little balloons. So when you have, these are the muscles and the nerves that work with it, with the airways, and so if those are constricted, see how they shrank and tightened around it? So now imagine your patient trying to breathe through, airways that are either wide like this, or now that they're constricted by these nerves, imagine trying to breathe through this. Okay, so a lot of the medications we give will help to relax muscles and nerves so that the patients can breathe through a normal airway. Questions? Let's see, so the brain controls the bronchial smooth muscle. The bronchi are innervated by the autonomic nervous system, so the larger airways. So we discussed a little bit last time that the autonomic nervous system has two divisions, the sympathetic system and the parasympathetic system. So when we stimulate the sympathetic system, we're getting bronchodilation, which we're trying to open up the airways, whereas the counter, if the parasympathetic system is being stimulated, now all of a sudden you're going to get bronchoconstriction. I just colored the letters differently so you can kind of note the difference between the different systems and what's occurring. The sympathetic nervous system, quick review, that was the fight or flight mode. And so when the sympathetic nervous system is stimulated, you're going to get an increase in heart rate, tachycardia, an increase in blood pressure because of the increase in heart rate. You're going to get pupil dilation, an increase in metabolism, but all of this will lead to a relaxation of the bronchial smooth muscle. Because your body is trying to get going because of the fight or flight reaction, all of these things are enabling the ability to anticipate danger. Whereas the parasympathetic nervous system, the opposite, not the opposite, yeah. The opposite, that's rest and digest, so it's just going to be the opposite of everything we just discussed. So decrease in heart rate, decrease in blood pressure, but now when that's stimulated, you're going to have bronchoconstriction, you're going to have a decrease in metabolism, you're going to have more saliva and mucus production, and so everything that you're going to give is to pretty much combat or counteract the parasympathetic nervous system being activated. Normally in homeostasis, the body has a balance between the two. Unfortunately, when we see patients in the hospital or in the healthcare setting, their balance is off kilter, and so we're trying to help them out with that. This is where I will try really hard to go through these questions for this particular one because there's a lot of neuro stuff that I don't think is super in your RT forte. So acetylcholine, which was one of the neurotransmitters we talked about before, it's broken down by this enzyme, acetylcholinesterase. This is occurring in the sympathetic and parasympathetic preganglionic junction, so at the beginning, but then also in the parasympathetic system, it can be also at the tail end of the transmission. Another neurotransmitter, norepinephrine, which we talked about. This one is working in the sympathetic post-ganglionic junction. Let's see, chemical mediators. So these are the two different systems, parasympathetic and sympathetic. These are the receptors that we're looking at. So nicotinic, just like the word in kind of sounds like, with regards to nicotine. those are being stimulated. We're more concerned about this muscarinic receptors. That's where your atropine, Atrovent, and all those will come into play. Because if we can relax these, then that will help open up the airways. With the sympathetic system, the receptors are classified as adrenergic. And so alpha receptors, these are all receptors. So there's alpha receptors, beta 1 and beta 2s. So with alpha receptors, when they are stimulated, we're going to get vasoconstriction, and what you would anticipate is now, their heart rate's going to go up, their work of breathing's going to go up. So like if beta 1 in the heart is stimulated, now you're getting an increased heart rate. But that's what we anticipated, because when we talked about the bronchodilators like albuterol, we're getting bronchodilation, but what else is going to happen? The beta 1, just like we talked about earlier. Let's see, dopamine's in there as well. So the heart is connected to the kidneys in a way that the increase in blood pressure can greatly affect the functioning of the kidneys. And so if dopamine is stimulating the kidneys, the arteries in the kidneys will relax and you'll get increased perfusion, which is super helpful. So normal, so parasympathetic. So when it's normal, everything is copacetic. Your nerves and muscles are open, they're dilated, but when that parasympathetic nerve is stimulated, we get that bronchoconstriction that we saw earlier. This is some of the, nerve pathways when stuff is stimulated. These are the neurotransmitters, the different nervous system stuff. I will promise I will be very lenient when it comes to the quizzing and this stuff, because you're not going to see it in clinic. Alpha receptors are in the arteries and the veins. So when those are stimulated, we saw earlier, vasoconstriction. Beta receptors, beta 1 in the heart and beta 2 are in the lungs. So it's always easy to remember beta 2 affecting the lungs, and you have 2 lungs. Beta 1, you have only 1 heart. That's one way to look at it, if that helps. So when we stimulate the beta 2, we get bronchodilation, but you're also going to anticipate increase in heart rate, which will increase the force of the contraction. The sympathetic nervous system in the lung. So there are, like we saw, there are nerve fibers that directly surround the bronchi and the airways. And so we're trying to relax those. There's neurotransmitter receptors, there's also hormone receptors that can affect all of that. Talks a little bit about these catecholamines. They're a class of neurotransmitters, but also medications, but we don't see that too often in clinical setting. Here is, I think it's a helpful list for you guys to kind of be aware of as far as the systems and where it affects it and how it affects it. Questions about that? It's a lot. I know it's a lot. But the more you know at least where some of the things are occurring, you'll have a better idea of how to approach it. Bronchodilators. So I was just looking at this. So beta adrenergic, so cyclic AMP, it's a cellular signal that binds to and regulates ion channels. Now in AMP, you guys will talk about potassium channels, ion channels. Just know we're trying to stimulate it so that their airways open up. Let's see, there's anticholinergics. That's where the Atrovent and atropine and all that comes into play. We're trying to relax the smooth muscles, which lead to vasodilation, which increase blood flow, but that also opens up the airways as well. Methylxanthines, like I said, we don't see these too often in practice. Let's see, bronchodilators already talked about it. Beta 2 stimulation, we get bronchodilation. Beta 1 stimulation, increased force contractions, increased heart rate. Alpha stimulation, that would cause vasoconstriction as well. Mechanism of action, so this is literally like the steps. I don't know if the quiz will require you guys to know like this process. I will try to take out any questions that get too crazy with this mechanism of action. Let's see, development of beta agonists. There's a lot of chemical structures. You won't see this too often with respiratory therapy. Has anybody taken OChem 1 or OChem 2 at all? Okay. OChem 1 and OChem 2 are designed to discuss chemical makeups, chemical structures, and how things work. That's why it's talking about a benzene ring and 2 hydroxyl groups. Don't worry about that. There are 3 chemical classes of sympathomimetics, catecholamines, salginins, and this other one. We don't use the first 2. So this is the chemical structure for catecholamine. We don't care. More structures, still don't care. Let's see, so they were used as dilators before, but they're not now. They do have a rapid onset. There's a short duration of action. These are enzymes, the COMT and the MAOI. It's no longer used. Oh, never mind. Some are used. So there's epinephrine, the norepinephrine, racemic. You'll still see those, but not too often for the purpose of you working as a bronchodilator, unless you got patients who have like croup for babies and stuff. But we don't see racemic epinephrine given too often. This other class, the resourcinols, I haven't seen that. Terbutaline, I've seen given, like it says, to stop premature laboring, but we don't use it or see it too often for respiratory. This we will see. I don't know if you'll need to know that these class of medications are saliginins. I've never heard anybody refer to it as that, so take it with a grain of salt. But for the most part, these class of medications have a rapid onset. But as far as their length of working, SABAs, short-acting beta agonists, can last between 4 to 6 hours. So for like a PRN albuterol treatment, you might see the doctor's notes will say, albuterol, nebulizer, SVN, Q 4 to 6 PRN. Whereas our long-acting ones, they can last between 12 hours or more. So some beta 2 specifics, albuterol, love albuterol, salmeterol, formoterol. This last one, this Indocarol, I've never seen that. So LABA, long-acting, SABA, short-acting. This wasn't in this particular slide, but I'll throw it in there, part of this lesson. So something like Advair, Symbicort, those are all medications that have usually a LABA and a steroid. These are intended for maintenance. So whenever you look at medications for patients, there's 2 classes, either emergency or maintenance. Those are, for the most part, the 2 most generalized ways you can look at it. So your albuterol, like we saw earlier, MDI, that's your emergency inhaler. But like the Flovent earlier, that would not be an indication for using Flovent if they have an asthma exacerbation. Flovent is intended as a maintenance med. Same thing with Advair. Advair is a mixture of 2 medications, one long-acting and one steroid, to kind of help keep things in check and keep them from getting flared up. Who knows what is an important educational moment with regards to a patient in Advair? What do you need them to do after they use it?
Rinse their mouth.
Rinse out their mouth. Why?
Steroid.
The thrush, right? So there's a steroid, there's thrush. Has anybody had a patient who's had thrush? Yeah, how did that go?
Well, she didn't have it right then, but she said that it's really painful.
Okay. It's really painful, it's sore. Sometimes You know, unfortunately, the steroid can allow other bacteria to be opportunistic and come in and wreak havoc. And so, yeah, you definitely want to make sure every time, even if it's something as simple as just rinsing with water, that's perfectly fine.
What is the risk if they swallow it? Because a lot of patients I had with the, I tell them not to. They're older people, but they just swallow it. Like rinse, rinse, rinse.
I think it's fine technically because you have stomach acids that are going to, you
But
know.
what about the esophagus?
I've never heard, honestly, I've never heard of patients getting thrush in the esophagus. It's usually just an oral thing, and it's a lot more noticeable like on their tongue. Like they'll have like a white filmy.
I've never seen.
Yeah, it's pretty fun.
Babies will get it.
Yeah, babies will get it pretty often, and so like I said, if they can, even just drinking something, like say if it's a baby who's getting an oral steroid, even if they just drink water, just kind of getting it out of the oral cavity is half the battle. Yeah.
What is the purple medicine that they put on your mouth?
Gentian violet.
See, look it.
So, how many of you ever seen gentian violet before? Okay.
I just did.
Okay. Do you guys know what it used to be used for?
No.
So it's like an all-natural, like antibacterial, antifungal. It's kind of old school, but it's actually been super helpful. Like if you have to apply it to say like an injury, like it'll help keep it clean. The only thing that sucks is it will stain anything and everything. So when you see it or use it, just be like gloves and just be aware that if it gets on you, it'll stick with you for a minute. But that's a benefit, like say for babies in that instance, where you don't have to worry about it being rinsed off, or if they eat or drink it being washed off easily. It's there for a minute.
How long does it last for usually?
It can last several days. Just depends how often. Like in that instance, if it's oral, like how often they're eating and drinking. Mm-hmm. But like I hurt my foot, and so after I had surgery, like my doctor's all like, oh yeah, you just slather that bad boy on there, put a patch on, a Band-Aid, and just make sure you don't, touch it to your clothes or anything. But it can last a long time.
Cool.
Let's see. So there's an example of a Methylene Mdi. You're going to make sure that it's appropriately labeled with your patient's name. Please make sure when you guys go into the med room and go grab your patient's meds, that you grab the right, even if it's like coming out of the bin that says the patient's name, there should be a label on the actual MDI or DPI. Make sure that's your patient, not somebody else's, because you don't want to give them somebody else's meds. Has that happened? Yes. Here's an option or a picture of a DPI Ceravent. So this is Salmeterol. I know a lot of companies have steered away from like a lot of solo meds, so like Ceravent I don't see too often because like Advair, a lot of other companies, it was more marketable to put it in combination with something else. Side effects, a lot of the things that we saw earlier with, Bailey.
You can call me whatever.
With her slides, she discussed a lot the tachycardia, the tremors, the nervousness, hypokalemia. So when a patient gets like a supranib and the tremors are occurring, it's actually because, not to get off track, it's actually because the patient's body is actually forcing out a lot of potassium in their body. The potassium is what helps to regulate those ion channels. And so if a patient complains too much about the tremors, what they can actually do is give the patient some potassium. They usually see a banana bag. Has anybody seen a banana bag before? It's an IV bag, it's yellow, but it has a bunch of potassium in it, and they can actually administer that to the patient to stop the tremors because they're now force feeding potassium into their body, and that'll stop the tremors. So, banana bag.
Would they do that before they give the albuterol?
No, it's not because it's such a common side effect, they're just like, oh, you'll be fine. But like if it got out of control, or say if there was a patient in the an ICU where after they got the breathing treatment, their tremoring could have long-term repercussions, then they would give them a banana Mdi to help with that.
What's the top three for Loxus?
The which one?
The first one.
I think that's a nosebleed.
Let's see.
No, I'm gonna Google. And if it's not that, I apologize. But I thought that's what it was.
It says the banana Mdi oral solution. Do they drink it?
No, IV.
The moment says oral solution.
Rapidly diminishing response. Okay, never mind. It was not the nosebleed.
What is
So
that?
it's diminished response to the medication. So it just means that a medication is less and less effective. So that might be like if you give if you give a beta agonist, then all the other stuff won't work as well. Don't worry about it. Let's see. So this is a very good chart of the different classes of medications, their route, their dose, their frequency. This might be an important one to know for the quiz. As part of that one. This one divides up your LABAs and your SABAs. Any questions about any of that? Let's see. Cerebent, you'll see. Fortil, you might see. This Brovana and Respimat, these ones are newer. You may or may not see those. Those are unfortunately super expensive, so you might not see those as often. But like Albuterol, Albuterol is super cheap. Advair is super expensive, so you will see a lot of patients who might not have the ability to have maintenance meds, and so you might see them as frequent flyers in your ER or on your floor because they cannot manage their breathing appropriately. And it's due to cost. And in my head, I'm like, it's going to cost more to get admitted to the hospital or to go to the ED than the top $400. I mean, Advair can be as expensive as $400 or $500.
Jeez.
For a 1 month supply. Anticholinergic bronchodilator, so we're stimulating, or stimulation of the parasympathetic system will result in bronchial constriction. And so we're trying to block this. And so atropine, that one you'll see a lot, but Atrovent you'll see a lot. You'll see more often for, like a duo nib, Albuterol and Atrovent. But just know that Atrovent is not a bronchodilator in essence. So with anticholinergics, the lungs are innervated with the vagus nerve. Stimulation will result in a decrease in heart rate. This is the breakdown in the parasympathetic system of the enzymes, which eventually leads to bronchial constriction. So at the muscarinic receptors, an anticholinergic blocks acetylcholine, which allows for bronchodilation. So this is the mechanism of action of what's actually taking place. This is another this is for like the muscarinics that we were just discussing. So this is the system, this is what's occurring, this is the bronchial constriction. But now with the muscarinic, this purple block here is supposed to be a diagram of what we're actually doing. We're stopping these neurotransmitters from attaching to the receptors on the nerve, which would in turn cause the constriction. Atropine can cause bronchodilation. It's not used as a bronchodilator, it's one of its side effects. It can inhibit mucus production and increase heart rate. Atrovent, there's your go-to. Ipratropium bromide, nebulizer, MDI, nasal spray. It's a short, it works as a quick onset SAMA, so the short-acting muscarinic agonist. That's what that is. Unfortunately, it can it doesn't affect the heart rate or the blood pressure or the GI tract. Just let the patient, if you need to, if they ask, oh, what's the side effects? Dry mouth, blurred vision, headache, not too common or seen too often. So the Rebound Mdi, sometimes doctors will write for this. It's another chart for common parasympathetics. This Rebound Ellipta, that's a new one on the market. You may or may not see that one often. I've seen Tudorza maybe once. Spiriva used to be super popular, but I'm not seeing that one too often. Have any of you who has administered Spiriva to a patient before? Okay, walk us through how you would educate a patient on taking Spiriva.
I think the ones we have, we would, just a canister and then you just inhale it in.
Oh, was it an MDI? Oh, okay. Okay, I apologize. So Spiriva is now available as like an MDI or the other one, I can't remember.
DPI?
No. Well, it is a DPI. So the one I was thinking of, there might be a picture of it later on. So it'll come as a capsule, like a plastic capsule.
Just spray in the air before once you open it.
No, that's priming it.
Turn.
No, this one you put the tablet. You actually put the capsule into it, and then afterwards there's a little button on the side. They're going to puncture the capsule, and then they're going to inhale it. So that was like how when Spiriva first came out. That's how we would have patients do it. Its duration, it'll last about a day, so it's just a once a day thing, usually in the morning when you guys do your rounds.
I did this one. Is this MDI?
Yeah, so that's the Respimat. That's the spring-loaded one. So the handheld, the dry powder DPI one I was talking about, that was the one I was talking about. The picture we just saw was the Respimat. So Respimat came on scene maybe about 8 years ago. That was to help patients not have to work on their timing for their dry powder stuff. You may or may not see RTs debate whether or not you slap a spacer on that. Just kind of be flexible in case they do weird stuff. RTs do weird stuff sometimes. Can cause dry mouth. I usually, if I ever administer a DPI to a patient, or even an MDI sometimes, even though it doesn't have a steroid in it, I think it's safer and cleaner for them to rinse their mouth out. So, just let them know, hey, we're going to rinse your mouth out. Here's a cup of water. Rinse and spit. Tudorza or Pressair, long-term medication, twice a day. It is a DPI. It's for COPD. These are its side effects. Like I said, I don't see Tudorza too often. Seabree, I don't see that one too often. Let's see, Rebound Ellipta, that one is coming on. There's a bunch of new inhalers coming on. They're kind of expensive, so your patient may or may not go with it. Be a good patient advocate. If you, based on your experience and what you see, if you don't think it'll be beneficial for the patient, then say something. Discuss it with the doctor. They may or may not agree with you, but try your best to look out for your patient. Because in some instances, I've had patients who felt like everybody was just trying to force all these different treatments, medications, therapies on them. When I would have said, hey, decline the smoking cessation. You might not need oxygen, might not need the breathing treatment, because ultimately when they get that bill, it's astronomical. So, like I said, be a good patient advocate. Increase Ellipta treatment once a day. Breath activated. So I can't remember what the other one was. There's another one. It's a turbo inhaler. Until most of them, it's a calm, easy breathing inhalation. Others, it's a fast, hard, and rapid. you'll get familiar with them as they come along. So this is the one I was talking about. So this is the handhelder. So this is where you put the capsule in. So you open it. Each one of those capsules is individually wrapped. You'll break the seal, place it in here, close this up, and then there's a little button right here, this little turquoise corner. That's actually a button where it'll puncture the capsule, they'll inhale it, and then when you're done, open this up, discard this capsule, throw it back in the box, and take it back to the med room. Like I said, I make it a point if I do most of these breathing treatments, like a DPI or an MDI, I'm like, hey, it can't hurt to rinse your mouth out. Especially you won't have that medicine taste in your mouth. This Adora Ellipta, I've maybe seen once or twice. This one's expensive. That's an inhaler. Albuterol, Combivent. So you'll see sometimes Combivent or Duaneb, either as a nebulizer. It'll be generic if you do it via neb. The Combivent is the MDI and brand name for it. Let's see. Some lavas are associated with asthma-related deaths. I'm not sure what that is, but they always like to disclose, like, hey, by the way, should you use this product, one of the side effects could be death.
What was the M in SAMA stand for? Muscarinic or?
Muscarinic.
Okay.
Live or die.
Let's see, so we're also going to be monitoring outcomes of our therapy. So you would I know for Intermountain, I believe, when you do your charting, it'll ask you what their sats are, your heart rate, respiratory rate, BP, O2, worker breathing before treatment, and then you'll reassess it after treatment. You can wait like 5-10 minutes after the treatment is done to reassess them. So those are things that we're looking out for them when we assess them and then reassess them. There might be times where, so these are effort dependent, so that like you actively have to, coach the patient when you're doing assessments like this. It's like the FEV1, the PEFR. I don't remember what the PEFR is, but I know the FEV1 is super important, and you'll see that these measurements and stuff like that during PFTs, pulmonary function testing. That's another one. Who was it? An older lady with dark hair with glasses that you saw for PFTs, or was it somebody else?
Yes.
I don't remember her name, but she gets super animate. Like, she gets gung-ho. She's like, you gotta breathe, 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 breathe. And I'm like, oh, I don't know if I have enough energy to do this.
Yep.
Let's see, indications of positive response. So your worker breathes. So these are all what you would expect if the treatment was successful. So decreased worker breathing, vital signs look better, decreased wheezing because we've opened up those airways. O2 sat should be good, and increased or better FEV1s. If I remember correctly, they use the FEV1 measurement to classify emphysema or asthma. So FEV1, be familiar with that one. But this is what you're looking for. This is the end goal when you give a patient a bronchodilator. Be aware, just another tidbit, when you do O2 sats and you put the pulse ox on a patient, if you're getting bad sats or a bad signal, switch the fingers. And if a patient is female or male and they have nail polish, grab some, I think an alcohol wipe will do it. Remove the nail polish from their fingers and then put the O2, pulse ox back on them, because something as simple as nail polish can affect how good of a reading you get. If your patient is ventilated or they can't do they have poor perforation in their fingers, you can go to the toe or you could go to an ear. How many of you have seen pulse ox on the earlobe? Okay, that same one that you use for the earlobe, if you can't get a good reading on the earlobe or anywhere else, you can actually put it on their lip. That's another option for checking their O2 sats. Move it around, and if you're getting if you move it around and you're still getting bad signals, that's an indication where the patient is legitimately crapping out, and so that requires a lot more intervention from the team, the healthcare team. Let's see, muscle tremors are the most common, like we talked about. That's the potassium being forced out. In this case, it's staying to stop treatment if the heart rate increases by 20 beats per minute. Like I said, when you do your charting, it'll say what they look like before and after. Unfortunately, at least for Intermountain, you almost have to like sit there with your charting open and wait until they're done before you can reassess them. Other facilities, I think like the you can do it, you can chart it, and then it'll go to another page before it asks you what your post-assessment readings are. Monitor your patient. If you ever have problems, contact your provider. Make sure you document everything. If you didn't document it, it didn't happen. And if something bad happens, you want to make sure that you crossed your T's, dotted your I's, and made sure that you documented everything. It's always better to over-document stuff than to under-document. Let's see, for inhaled medication administration, coaching, how you explain to the patient how to use it is super important. Sometimes if you need, when you're coaching them, you might want to have them demonstrate or explain back to you that they are aware of it. I think I had one coworker tell me, they asked the patient, hey, do you know how to use your Advair? And they said, sure. So on the Advair, you have to puncture it, but you just click it. You have to click it and then inhale it. But the patient clicked it and then like put it on, or yeah, they put it on their neck almost like perfume, like they were dabbing it. And there's RTs will always talk about an episode of House where a patient, they asked him, hey, show me how to use your albuterol inhaler. And they did the same thing. They're like, psh, 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 psh. So it might seem annoying that you have to do, but you know, you have to approach every patient like they have never done it before, at least until they can show you, redemonstrate back to you that they know what they're doing when it comes to their home meds. You might share something with them or show them something that they have no clue about, and they will be more appreciative for sure. Sometimes patient and family education is important. If the patient can't do it because they're either too young, too old, or just not mentally with it, family member, friend, or loved one, if you can educate them as well, the more people who know how to do it correctly, the better off the patient will be. The patient can only be as good as the instruction he or she receives, so DPIs, MDIs, when it comes to spacers, you know, however good you coach them, and they re-demonstrate it back to you, the better off the patient will be. You'll have a lot of patients who you ask them, do you know how to use a spacer? And when they show you, they'll suck in as hard and as fast as possible, and then you'll hear the whistling or the harmonica sound. And we have to stop them and let them know, hey, when you hear that sound, it means that you're breathing in too fast, that the effectiveness of the medication will not be as good if you're inhaling too fast. So whatever you can do to help them, the better. I don't know why it throws this methylxanthines up in here. Theophylline, aminophylline, and caffeine. There are medications that are around the hospital, but you won't ever use them as an RT. But you know, the care team can use them in other ways to help the patient. If I see any questions regarding theophylline or aminophylline, I'll take them out because they're not super helpful for you guys. So in summary, mechanisms of bronchial constriction, bronchospasm, secretions, inflammations. We're trying to reverse the bronchospasming. We're trying to thin out the secretion so they can cough it up and get it out. And we're trying to reduce the inflammation. The inflammation, I would say, isn't something that we can per se help out with, but the care team can help with that. And if we can take care of the inflammation, then everything else will be better and it'll be easier for the patient to breathe. The lesson was to help us kind of understand how bronchial constriction takes place, and when you administer your medication, how we're trying to offset that. Nobody cares about the long chain amine. Bronchodilation can be achieved with sympathomimetics and anticholinergics. So that was our albuterol, and this was our Atrament. There are different classifications of bronchodilators, the LABA, SAMA, LABA, and SABA. It's important for us to understand the sympathetic nervous system, the parasympathetic system, and there's a lot of repetitiveness. Any questions? I know it was a lot to go over. Any questions about anything we discussed so far? Any questions about anything we've just gone over at all, period? We have one presentation next week. We'll go over quizzes, and I apologize, I'm trying to get with the timing. All of a sudden my work is busy, so if I don't get to like correcting stuff as fast as you would like it, because you're overachievers, I apologize, I'll try to get better at that. Questions, concerns, comments?
So for this quiz, those 2 charts you pointed out to memorize for like the dosages
That might,
the quiz?
I don't know if those will be on the quiz, but those are, in my experience, would be helpful for you to know just going forward in general.
Okay.
If something is, if I know ahead of time, like quiz-wise, I'll try to look at the quizzes before we come in and see if we'll, and try to point out things that might be pertinent to it. I'm gonna let you guys know. All right, if you guys have questions, concerns, comments, shoot me an email, shoot me a text, give me a buzz. Other than that, thanks guys, and have a good one.
Thank you.
I believe in you.
Oh yeah,
Try on the
jacket.
jacket, see if you like the size. I mean, it wasn't a pretty different thing, but just check out the jacket if you guys want.
No. Will you go check if we're up to her? With me?
Huh? I was gonna see if you wanted to go get dinner later today. But
I think you can.
I was gonna be down there for Thursday, but she just canceled.
Oh. Oh, well, I was gonna say there's a sushi.